Good afternoon, everybody, and thank you very much for joining us today. My name is Mark Summeray, and I'm Chief Medical Officer at Amolyt Pharma, and it's my pleasure to welcome you to this Amolyt-sponsored KOL event. We are very fortunate to be joined by two other people today. The first is Professor Istvan Takac, and the second is Deb Murphy. Just briefly, a few words about both of them. Professor Takac is Professor of Internal Medicine at Semmelweis University in Budapest in Hungary. He is an endocrinologist and also a clinical pharmacologist and head of the Hungarian Osteology and Osteoarthritis Society. Of course, even more importantly, he has been an investigator in the phase 2A clinical study of AZP3601 in patients with chronic hypoparathyroidism. And he will be presenting the data from the first patient cohort in that study. And as I mentioned, we're also very fortunate to be joined by Deb Murphy, who has hypoparathyroidism and has very kindly agreed to share her perspectives with us today so that we can understand the impact that hypoparathyroidism has had on her, and also perspectives that she probably has based on her knowledge of other people who also are suffering with this condition. So let me move to the agenda. So you'll see that we're going to start with a discussion that's focused on the development of AZP3601. And I'll be providing some background in terms of not only the disease, but how the drug has been designed in a way that we believe will provide a new option, a new treatment opportunity for patients with this condition, which we hope will deliver clinical benefits that they haven't been able to enjoy up till now. After my talk, Professor Takac will give you an overview of the data from the first cohort of the first patient cohort of the clinical study, and then we will ask Deb to share her perspectives with us. And following that, there'll be an opportunity for Q&A. So, as I mentioned, I'm going to be focusing really on the rationale for the development of the molecule and how that fits with our understanding of the disease. I'll be talking about the unmet medical needs in hypoparathyroidism and the fact that patients really don't have good options today which give them satisfactory symptom control and prevent long-term complications. I'll also talk a bit about parathyroid hormone, which is the hormone that's missing in this disease or deficient, and the goal of treatment in terms of how we should address that deficiency of parathyroid hormone with respect to parathyroid hormone physiology. I'll also talk about the goals of treatment with respect to controlling calcium levels in the blood and restoring normal kidney function with respect to reabsorption of calcium that is lost in the urine in patients who are unable to reabsorb it. And finally, I'll also focus a little bit on the bone. Having said that, I'm going to link that to the design of AZP3601 and explain why the pharmacology of this molecule has been rationally designed in a way that we believe will offer patients a solution to not only symptom control, but also restoration of normal kidney function, ability to reabsorb calcium specifically, and avoid detrimental effects on the bone, which many of these patients are vulnerable to suffer. And then finally, I'll touch briefly on some early clinical data that was generated in healthy volunteers. So hypoparathyroidism as I mentioned, represents a disease with significant unmet medical need. It is a rare disease, and it's characterized by deficiency in parathyroid hormone that results in dysregulation of serum calcium and phosphorus levels. And usually it's caused by inadvertent removal of the parathyroid glands during surgery on the thyroid. It affects approximately 80,000 people in the United States and about 110,000 people in Europe. And of those, roughly half are peri or postmenopausal women who are at risk of developing or who may have already developed osteoporosis. And for many decades, conventional treatment for this condition has simply been replacement of calcium by supplementing large amounts of calcium by giving tablets, and also the active form of vitamin D to help calcium to be absorbed from the gut. So there are actually primarily three therapeutic goals that are linked to the three things I've already mentioned: the symptoms of the condition, the kidney, and the bone. To be more specific about the symptoms, they relate to the fact that calcium levels in the blood are abnormally low and difficult to control with normal therapy. And so patients complain that they suffer from disabling symptoms, including what they describe as brain fog, or difficulty concentrating and difficulty with memory, which is very debilitating. And they suffer these symptoms quite frequently during the day and at night. Other symptoms include neurological and muscular symptoms, strange tingling sensations, paresthesia, muscle cramps, and in severe cases, even muscle tetany. And these symptoms are very debilitating for the patients, and they really impact their quality of life. Now, from the perspective of the kidney, as well as the bone, there are longer-term complications of the condition. About half of the patients have too much calcium in the urine, so the kidney is unable to reabsorb calcium that's filtered, and the calcium ends up in the urine, and that's damaging to the kidneys. So about a quarter of patients with this condition have chronic kidney disease, and they have also a high risk of developing kidney stones, which can also be damaging as well as extremely painful. So one of the goals of therapy is clearly to decrease the damage to the kidney by restoring the kidney's ability to reabsorb calcium and prevent the damaging effects of calcium in the urine. And as far as bone is concerned, as I already mentioned, many of these patients are peri or postmenopausal women, and they are at increased risk of osteopenia or osteoporosis. So another therapeutic goal is to restore normal bone turnover and avoid any situation where patients are subject to an increased risk of further bone loss, and that could lead to a risk of fractures. A little bit more detail on the kidney and the bone here. Guidelines that are written to help physicians manage these patients reinforce the importance of monitoring patients' renal function and minimizing hypercalciuria to try to mitigate the risk of renal injury over time. Despite this, just over a third of patients have kidney stones. Slightly more than that, about 38%, have nephrocalcinosis, which is a direct excess calcium toxicity problem in the renal parenchyma. And about 20 to 30% of patients get kidney stones and nephrocalcinosis. And over time, more and more patients actually develop chronic kidney disease. So it would be desirable to have a treatment that would allow these patients to have a protected future for their kidney. And that could be achieved by withdrawing these large amounts of calcium that they have to take to keep the calcium levels up in the blood, which unfortunately make this problem with calcium in the urine worse, because you're presenting more calcium to the kidney, and the kidney, in the absence of parathyroid hormone, isn't able to reabsorb that calcium, and it ends up in the urine. In addition, decreased PTH leads to a situation where these patients have an abnormally low bone turnover state, and they have an increase in bone mineral density because they're not turning over bone. The bone is actually in almost a sort of dormant or frozen metabolic condition. But the microarchitecture of that bone, even though it's more dense, isn't normal. And certainly there's more and more evidence emerging that these patients are at increased risk of fractures. So in patients who have non-surgical causes of hypoparathyroidism, increased risk of vertebral fractures specifically, and in post-surgical hypoparathyroid patients, they're at increased risk because most of them have osteopenia and osteoporosis related to the fact that they are peri or postmenopausal women. So a treatment imperative here is that we shouldn't worsen the situation, and ideally we should improve the situation by restoring normal bone turnover. It's actually quite an amazing fact that hypoparathyroidism was really, until recently, the only remaining classic endocrine deficiency that did not have a replacement hormone for treatment. And it's important, thinking about how to replace the function of parathyroid hormone in these patients, to understand what normal parathyroid hormone physiology looks like, because parathyroid hormone levels are not just a simple continuous level all day and all night, but normal parathyroid hormone levels actually vary in a circadian fashion. So they vary over a 24-hour cycle, but they also have small amplitude and high frequency pulses that are superimposed on that background level of parathyroid hormone in the blood. And that's the normal physiological situation. So I don't think it would be accurate to think that you can simply replace the hormone by creating a situation where you have a continuous and even level of parathyroid hormone in the blood, because that would not be physiological by definition. So this brings me to the last point on the slide, which is that neither an infusion-like profile of parathyroid hormone nor short exposure administrations actually mimic normal physiology. And we know that based on preclinical data, multiple models show that if you give continuous non-pulsatile exposure, you actually cause bone loss over time. So continuous non-pulsatile elevation of parathyroid hormone or parathyroid hormone related protein, which happens in certain malignancies, is also known to increase bone loss and increase fracture risk. We know, in contrast, that if you give short exposure with intermittent administration of parathyroid hormone, you can increase bone volume. But that intermittent exposure has a disadvantage, of course, because it doesn't give you continuous control of serum calcium levels over time, by definition, because of the variation in the amount of parathyroid hormone effect. And we note that with the first hormone that became available, Natpara, actually there were these variations in control of serum calcium, and patients did suffer adverse events, including hyper and hypocalcemia episodes and vasoactive events. So this molecule, AZP3601, has been designed specifically to address what we need to deliver in terms of trying to restore normal PTH physiology. And the target here that we want to achieve is a long effect such that we can even out these swings in calcium levels. We want to do that by restoring normal renal calcium reabsorption, as I mentioned, and eliminate the need for these additional supplements, these calcium supplements and active vitamin D. But we would also want not to expose the bone to this continuous background level of parathyroid hormone. So what we want is something that's having a short effect on the bone, that's not constantly present, in order to stimulate some bone turnover that's balanced, not too much formation or too much resorption. And on the right side, you can see the receptor pharmacology of AZP3601. And this is an important point because the binding of AZP3601 to the PTH receptor, depending on whether that receptor is found in the kidney or is found in the bone, we believe influences the conformation of the PTH receptor. And it exists in two conformational states, R0 and RG. And in the kidney, when AZP3601 binds to the PTH receptor, the receptor is in the R0 conformation. And that results in a very long, prolonged pharmacodynamic effect because the drug binds to the receptor in the R0 conformation. It gets internalized within the tubular cells in the kidney, and multiple cycles of G protein coupled activity happen, and cell signaling cycles inside the cell, giving a very prolonged duration of action. In contrast, in the bone, the PTH receptor is in the RG conformation when it's bound to AZP3601, we believe. And so therefore, the interaction there is very different because the signal is much shorter. You don't get these repeated cycles of G protein coupled signal inside the cell. And actually the signal that results from binding the drug to the receptor is really just a once-off interaction. And so it's going to continue as long as the ligand or as long as the drug is present. So because AZP3601 has a short half-life, it's not present that long, so it has only a very intermittent and short-lived effect on the PTH receptor in the bone. And these are really important physiological, pharmacological facts to understand because they are behind the rational design of the molecule. This leads to another important point. AZP3601 is not parathyroid hormone, not the whole hormone, it's not part of the hormone. It's actually been rationally designed based on a combination of parathyroid hormone and parathyroid hormone related protein. And you can see here, the slide shows you how the starting point is the 1 to 36, 1 to 34 and 1 to 36 of those two hormones respectively. And then substitutions of various amino acids that were deliberately done with various iterations of the molecule in order to improve selectivity for binding to the R0 conformation in the kidney, and also giving it solubility properties that would make it druggable. In other words, you could use it, you could inject it, and you would have the right kind of PK profile. So this molecule is a rationally designed molecule specifically targeted to achieve the right PTH receptor pharmacology. And this is the evidence of that based on radioligand binding studies, where we can see the relative affinity of these different PTH analogs with AZP3601 at the bottom in the table there for the RG and the R0 conformation. And here you can see that AZP3601 has by far the highest affinity because it's displacing that radio-labeled ligand at the lowest concentration for the R0 conformation of the PTH receptor. And it has very similar binding affinity to the RG conformation of the receptor as the other PTH analogs. But of course, as I said, it has a very short half-life, so it doesn't interact with those receptors for very long. And there you can see on the right what I've already emphasized with respect to the effect on the bone, relative to the effect on the kidney, RG versus R0. These data just show the PK and the PD that I've mentioned are translated in vivo. So when you give the drug, you can see on the left side it has a very short half-life. So we're talking about here a half-life of around 8 minutes when it's given intravenously in rodents, which is similar to unmodified PTH peptides. But in contrast, it has a very long pharmacodynamic effect on serum calcium in a rodent model of hyperparathyroidism. So this is the last slide I'm going to present before I hand over to Professor Takac. These data were generated from the first part of the phase 1 study that was performed with this drug in healthy volunteers. As is classically the case, the phase 1 study was divided into a single and a multiple ascending dose phase. On the left side, you can see the single ascending dose data. You can see the very short PK, so the different doses there going from 10 micrograms single dose up to 120. You see the very quick peak and then the rapid decline in the concentrations of the drug. In contrast, though, you see the long pharmacodynamic effect, which is showing that the receptor pharmacology that I just described actually translates to what was intended. And on the right side, you see the pharmacodynamic effect in the multiple ascending dose phase of the study, where these healthy volunteers were given doses every day of the drug for 2 weeks. You can see that the serum calcium levels are dose dependently maintained when they're taken immediately prior to the next dose across the 2-week period. And the effect persists for more than 24 hours at the 2 low doses, and even more than 48 hours actually after the 2 highest doses. So all of this is very promising. The underlying receptor pharmacology, the rational design of the drug, the clinical data in healthy volunteers. But now I want to hand over to Professor Takac, who's going to take us through the clinical data in patients.
Just a second. Okay. I'm absolutely sure that now everybody understands that why the chronic hypoparathyroidism is the last endocrine disease which is not treated reasonable. Any other endocrine disease where the hormone is missing is treated by the proper hormone. But based on this data, what you can hear before, it's understandable that why it's so difficult to treat the chronic hypoparathyroidism. The data came from 1930s when János Scheyer wrote first time that the PTH has a Janus phase. It means that the effects depend on how we give or gave the rats or patients the parathyroid hormone. From this viewpoint, I can say that it's very, very interesting, this trial, and it's honorable for me that I can present for you the first time this phase 2 trial, which I think that could be a new part of the treatment of the parathyroid missing patient, the chronic hypoparathyroidism. One thing before I start the present the details, that I can see the lots of personal experience, because all of the parathyroid hormone treatment type in chronic hypoparathyroidism it was tried in my clinic in our phase 1 and phase 2 and some of the phase 3 trials. And my patients can speak really good data about the feeling, what they can feel under the treatment. And I can say that what we can measure about this treatment, as just mentioned before, before the Q&A part, because if you will have a question regarding other treatment and how can which is the possible connection, the methodology or the results to other treatment type, I hope I can answer it. Now let's go to the detail in this phase 2 study. The study was a phase 2, 3 months long, multi-center, and open label design. The study first part, the optimization period, when the patient received calcium, vitamin D, even if it was necessary, then 25-hydroxy-D and magnesium to achieve the serum calcium, albumin-adjusted serum calcium target range. The target range here was 7.8, from 7.8 to 9 milligram per deciliter. It means that all of the patients received the necessary treatment to be in optimal phase at the start of the study. The optimization period was from 4 weeks up to 8 weeks. It depends on how fast we can reach this optimized period of the patient. After this optimization period, the patient received the study drug, the AZP3601, daily, subcutaneously. 20 microgram was the starter dose. Every patient received the drug in abdominal area. And after this first starting dose, from the day 5 until the day 11, the active vitamin D and the oral calcium treatment was removed, step to step, following the protocol. And if I say my personal experience, it was the fastest changing from the old one therapy to the new one therapy regarding all of the other PTH type treatment of the chronic hypoparathyroidism. It means that all patients reach the target range on the day 14. And from the day 14, the patient AZP3601 treatment, the dose could be up titrated up to 60 microgram. It depends always from the investigator. And I have a slide about the dose.
Yes. Yeah.
Just I would like to, sorry for that, this is, yes, because it's important, because I mentioned that the up titration was allowed, but this up titration happened in rare occasion. Only 3 patients from the 10 was up titrated during the study. And therefore the starting dose and the reached maximum dose of the mean dose of the AZP3601 was very close to each other. It was just 30 microgram. Going back. So go back to the design. So the up titration was allowed, as I mentioned, during the study. And we measured the safety, the efficacy, and the pharmacodynamic effect of the drug in detail. The safety, of course, it means that we measure the adverse event, serious adverse event, drug-related adverse event in every visit. And the efficacy was measured, as is usual is this kind of studies, is measured with the percentage of the patient who reached the targeted serum calcium level, albumin-adjusted serum calcium level, without the calcium and active vitamin D supplementation. It's a very important part of the efficacy, because it means that it's enough for the patient, this kind of treatment, or needs to give other things, active vitamin D and calcium, to reach the target range. For instance, in NATPARA, it was not perfect in the everyday practice. This is the reason where the FDA approval included this kind of thing, that just plus to the vitamin D, active vitamin, and the oral calcium could be added NATPARA. And we, of course, measured the treatment effect on the serum calcium, serum phosphor, the urinary calcium, and the bone biomarkers as well. We measured this kind of things in the 2 cohorts of the patients, and first, now I present just the result of the first cohort because the first cohort ended until now. The first cohort, altogether 14 patients were included, and 2 patients were ineligible to main treatment period because of the lab values. It means that 8 weeks was not enough to normalize the 25-hydroxy, the magnesium level, or the patient didn't reach the target range of the albumin-adjusted serum calcium. So 12 patients was included in the main treatment period, and 10 patients completed the extension phase. As you can see, we had 4 sites, 2 in Hungary and 2 in Spain. Hungary won 9-3. And if I remember well, in the first cohort, we have 5 patients in the Semmelweis University. And here is the baseline characteristics. The patient mean age was 62 years. It's the usual age in the chronic hypoparathyroid patient group. The age range were between the 44 and 72 years. Most of the patients, can I show some? Yes, sorry. Most of the patients, I try to use it. So most of the patients were postmenopausal women with post-surgery etiology. This is the usual in this disease. It means that the patient population is show us the everyday life practice. The oral active vitamin D dose were 0.65 microgram. It's usually around 0.5 microgram in the everyday practice. And the oral calcium dose was 1.6 gram per day. It's a usual amount. It's usually around 2 grams per day in the everyday practice. It means that the baseline characteristics is proper for the normal patient population. I show you this up titration data before, and let's see the safety data. The AZP3601 was absolutely well tolerated. No serious adverse event was reported. The drug-related serious adverse event, it means that the investigator thought that the adverse event could connected to the adverse event, then a drug-related type. It was rare as well. Only 7 were reported during the study in 4 patients. And as you can see, the hypocalcemia, hypercalciuria, erythema at the injection site were rare as well. And let's see the efficacy. As I mentioned, the efficacy usually measured in this kind of study, the percentage of the patient who had a normal or targeted range calcium level without the active vitamin D and calcium supplementation. And here the active vitamin D, the patient 90%, and the oral calcium and the patient 80% was stopped during the study. It means that 9 of the 10 patients or 8 of the 10 patients was treated just with the AZP3601 without active vitamin D or oral calcium. And what is, of course, very important, during the treatment, the albumin-adjusted serum calcium level remained in the targeted range. What is, I think, one of the most important results of the study, that the 24-hour urinary calcium was normalized in all patients. This is the first study. However, the patients' number is until now is low, where every patient's hypercalciuria was treated with the study drug. And you can see that this normalization was really rapid, profound, and sustained during the study. It was through, and it's very important as well, that this fact was true for the patient groups who had hypercalciuria at the baseline. Here, the normalization was achieved by the day 28, but similarly rapid and profound was the normalization of the 24-hour urinary calcium. Based on the earlier presentation, you can understand that how important the data is. We measure the fractional urinary calcium excretion, and of course, this show us in absolutely same result, the rapid, profound, and sustained reduction and normalization of the fractional urinary excretion of calcium. And last but not least, about the bone biomarkers, the easy, as I heard before, it's very important because most of the patients are postmenopausal women at high risk of osteoporosis on one side. Another side, the chronic hypoparathyroid patient has a real bad bone turnover. Usually they have a frozen bone with a bad bone structure. It is the explanation why the chronic hypoparathyroid patient has a higher BMD together with the higher bone fracture risk. So go back to the study. The AZP3601 induced an increase in bone biomarkers, both of them, the P1NP, what show us the bone building capacity. This is an anabolic agent. And the CTX, what show us how the bone resorption working in the patient bone, and bone biomarkers slightly elevated after 2 weeks of treatment within the mid-normal range of postmenopausal women, consistent with the resumption of the physiological bone turnover. It's a very important result as well, I think, of the study. And let's see what we can say about, based on this first clinical data in chronic hypoparathyroid patient. It's very important the AZP3601 was well tolerated with no safety concern, demonstrated ability to eliminate standard of care while maintaining the serum calcium within the targeted range for duration of the study. And very important as well that the independence from the vitamin D and the active vitamin D and oral calcium supplementation was achieved as early as the day 14. The mean urinary calcium decreased within the normal range by the end of 14, and at the patient group who had originally the hypercalciuria by the day of 28 and continued to decrease throughout the end of the study. And both biomarkers of the bone turnover increased to the mid-normal range levels, consistent with the balanced increase in bone turnover. I think these data are really interesting from the first cohort, and the second cohort is ended now, some days ago, and data is currently being evaluated. I think it will understand us to understand better those relationships, and I hope that it inform us to design the phase 3 trial. Thank you very much.
Thank you. So thank you very much, Professor Takac. So we'll move straight on with what actually I think in many ways is the most important perspective that you're going to hear, which is the one from Deb, who, as I mentioned at the beginning, has very kindly agreed to share her experience of hypoparathyroidism with us. And hopefully, if the technology works, Deb, you're there, and we'll hand over to you so that you can let us know how living with this condition has affected you.
You really want to know, huh?
Yeah. Yes, please.
My name is Deb Murphy, and I'm a wife. I'm a mother of 3 beautiful daughters. I have a beautiful stepdaughter. I have 11 awesome grandchildren from ages of 1 to 11. And to say that God has blessed me is an understatement. My husband was in the Navy for 28 years. So that puts me a military wife. And I've had to learn to adapt in every single aspect as we moved every 3 years. But nothing prepared me for what happened in 1992. After thyroid cancer surgery, the surgeon took everything out. He said the parathyroids were encapsulated. So shortly after surgery, I went into a coma state. And there was nothing they could do because they didn't know what to do. They finally started giving me IV calcium, and I came around. But all they gave me was calcium, or actually not even calcium, it was Tums and ice cream. And that was supposed to sustain me. Well, I was in the hospital for 3 weeks because obviously that would not sustain a person. And then finally they had an endocrinologist who knew what they were talking about. And they gave me the active vitamin D. There were points when I would go to the bathroom and I couldn't get up because I could not feel my legs because of the muscle tingling. Finally, I got to that point where I was able to start my journey in the world of hypoparathyroidism. Back then, there were no computers, so there was really, well, they were just starting, so there was really no way to get to know what hypopara is or how to even find it out. My daughters at that point were ages 2, 4, and 5, and my husband was deployed in the Persian Gulf. I had moved close to home to Iowa to be close to my parents, and my children basically took care of me during this period. I remember one day I was laying on the couch, probably low calcium is all I could think of, but my children fed me cereal because that's what they could reach. I've always asked them what they thought about that time frame, and most of them say, yeah, I don't remember, but I'm sure they do. The one thing I learned to be was self-sufficient. I would end up being in the hospital once in a while, but I always seemed to manage. And at first, I mean, I was only 33 when this happened. And as I said, I learned to adapt because every 3 years we moved. So that meant every 3 years I had a new endo. And every 3 years they would change how they would do things. Some doctors would say, oh, let's take, 5 grams of calcium and 1 calcitrol. And then other ones would change it around and say, oh no, let's do 0.5 calcitrol and just take 1 calcium. So, and it never dawned on me to question it or say anything because they were the doctors, they knew. The other thing that I ended up with was nephrocalcinosis. My GFR went down to 35%. I have both nephrocalcinosis and kidney stones. I have 3 of them. Thankfully now my kidney function is back up to 45%, but that's through hard work and effort. Normal people don't have to think about how their bodies deliver calcium, that it goes through the bones and into their bloodstream. And it's a wonderful process that God came up with, but we have to fight every day to maintain that calcium in our bodies and keep our bodies free of those side effects of hypopara. We need to also watch our diet. If I eat too much calcium, I have to cut back on my pills because otherwise I will go hyper. We have to check labels. You'd be surprised what has calcium in it and what has a lot of calcium in it. For example, yogurt and almonds. If I take those 2, I do not take calcium that day. Almond milk has more calcium than regular milk, and didn't know that, and I went hyper once. The other thing we can't eat a lot of are beans and nuts and cheese and tuna. And Loretta wanted me to add spinach because they all have high phosphorus levels, which can cause kidney stones. There are so many side effects to hypopara. We may look normal on the outside, but on the inside we have brain fog, depression, poor memory, and I say it again, poor memory. We can get brain calcifications. We can develop Parkinsonisms. We can have arrhythmias, laryngeal spasms. We develop calcium cataracts on our eyes. We develop chronic kidney disease and kidney stones, nephrocalcinosis, muscle tetany, bone issues. Our bones are thick, and many of us have osteoporosis as well. I ran into a lady here. I'm at the Global Genes Conference, and her mother has hypopara, and she had to have bone fusions done because of how poor her bones are. Overall, we have poor quality of life. And I didn't even mention the most important aspect is the pain. We have bone pain because our bones are not turning over that calcium like normal bones. We have muscle pain. We have overall aches and pains. They're just a daily occurrence. I have said this before, if we don't die from hypopara, we will die from the side effects of it, because the side effects, I swear, sometimes are worse. And as you know right now, the only standard of care we have is calcium and the active vitamin D. And that is something that sustains us, but it doesn't do anything but keep us alive. At this point in life, I decided to get involved with the Hypoparathyroidism Association, which is an advocacy group. And we're looking to affect people's lives who have hypopara and who are caregivers of people with hypopara. And we've been able to see great things happen. And not one of them is this. And now that I've said all this ucky stuff, I'm going to say now to the hope. We have been so excited to see different treatments come to focus for us. And I know from discussing with other patients that we are very anxious to have our bone and mineral and our kidney health normalized. We need to find a way to keep our calcium in a normal range without having to deal with all this. And we're waiting for things to make our lives better. And I really believe today, with what we've heard from Dr. Takesh and also what we heard from Dr. Samurai, that we are on the road to having something happen. I really believe that amylite is going to make the difference in our lives. I really believe and am hoping for a great future. Thank you.
Thank you very much, Deb. So I'm just going to say a word in conclusion, although it's difficult to follow that testimony from Deb, very powerful. And then we're going to go to Q&A. So overall, I think the data that we have provides on AZP 3601 initial evidence that it has the potential to become a real treatment for patients with hypoparathyroidism with the potential benefits that I've mentioned earlier. We've identified what we believe is an appropriate starting dose, subject to the data that is to come very shortly from the second cohort of patients. As you've heard from Professor Takach, the drug was well tolerated, there were no safety concerns, and patients were able, in the vast majority of cases, to achieve independence from their calcium supplements and oral vitamin D, even in the short time of the study, while their mean adjusted serum calcium levels were maintained within the target range. The effect on urinary calcium, we think, is very important and hugely potentially impactful for patients, given that we saw rapid normalization, even in the patients who had high calcium in the urine at baseline. And the changes that we saw in the bone biomarkers suggested that we're achieving a resumption of bone turnover, which is in the physiological range. As has already been mentioned, there's a second cohort of patients that have just finished participating in this phase 2A study. We're exploring a wider range of doses because we're starting at a lower dose and we're allowing dose increases up to an 80 microgram dose. And we plan to use the data altogether to help us design the phase 3 study that we plan to implement next year. This is my final slide. I'm just going to reiterate actually most of what you've already just heard from Deb. That really one can think of the 3 major buckets of problems here with respect to the symptoms and all of the impact that those symptoms have on these patients and their ability to function and their quality of their lives. And then the longer term complications of the disease, in particular in relation to kidney and bone health. So I'll stop there. And at this point, we're going to take questions either from within the room that we have, people that we have in the room here, or in addition, questions that may have been submitted online.
So we're going to start with the questions in the room here, and then we'll move to what was submitted online. So I'll pass it off first to Ritu from Cal.
Thanks. I'll start with just 2 questions before getting back in the queue. The next dose cohort, starting at 10 micrograms, going up to 80, what's the main thing you're looking for from that cohort? Are you looking for a higher percentage of patients that will achieve supplement-free status? And, even within that, are you looking for day 14? Are you looking for, I think it was day 84 or day 90? What's sort of the bogey on that? And then I have an R0 versus RG question.
So the design of the study is the same. So it's the same treatment periods, optimization and then treatment and then maintenance. The reason for the lower starting dose is really to explore the dose range properly so that we can establish the ranges of dose versus response in these patients. It's partly to satisfy a question that came to the company from the FDA. They want always to make sure that you have data across a range of doses and that you have the data that you need to justify the starting dose that you use. The most important thing to bear in mind is that once the patient has started on the drug, the dose is adjusted on an individual basis so that each patient will obviously end up on whatever is the right dose for them. But in the beginning, we want everybody to obviously to start on the same safe starting dose, and then we'll see if we need to adjust the dose over time as we withdraw the supplements. So part 2 of this, the second cohort, will just give us more data and give us more confidence that we've identified the right starting dose for the phase 3 study and the right titration regimen in terms of when to adjust the dose and how to withdraw the supplements.
So would you expect that patients might normalize even faster, or will you not be?
Well, no, we wouldn't, because we're starting at a lower starting dose. We would expect probably, although some patients will probably respond to the 10 microgram dose, more patients will probably need to go up to 20 and then possibly up to higher doses over time. So it'll take longer actually to get to that point.
Understood. Okay. And then the R0 versus RG mentioned that R0 exists primarily in kidney and RG in the bone. Can you talk about the distribution and conversion in these tissues? Like, is this a dynamic sort of existence between the two states, and can that impact how patients respond, either interpatient variability or even intra-patient variability over time?
So I think I'd start by saying we have some data to support this hypothesis, and it's a rational explanation for what we see. So what I mean by that is the R0 conformation. So the PTH receptor is a single receptor that can exist in either one of these shapes, conformational states, R0 or RG. And we think the reason that the R0 conformation of the receptor is the one that AZP 3601 is binding to is a combination of the influence of the drug and also where the tissue. So in the kidney, if this drug binds to the PTH receptor adopts this conformation, and then the signaling I mentioned happens, and you get this very long pharmacodynamic effect. In the bone, it seems that the binding of the drug to the receptor causes the RG conformation, and then you get a very short, sort of on-off, more classic effect, so that you don't get this very prolonged effect that you can only achieve with RG binding if you constantly expose the bone to a drug that is binding to that conformation. So we have some data which shows that if you use a radioactive label for AZP 3601 and you follow where it goes, the radioactivity shows that in the kidney, there's a high amount of the drug that persists for a long time, which is exactly what you'd expect. But in the bone, it's a much smaller amount and it doesn't persist there for very long. So this is consistent with the hypothesis, but it is a hypothesis.
Got it. Understood. And thank you, Deb, for taking the time to give us your perspective.
Hi, John Walden, JMP. A couple for me. At the longer time points, it looked like there was a lowering of the serum calcium levels, but also an uptake in active vitamin D and calcium supplementation. Can you discuss, what's going on at those later time points and if those patients were titrated up as well?
Sorry, the question is what will happen if we up-titrate the patient?
It seemed like from the data that the serum calcium levels were dropping over time.
Yes. Okay, it's a reflex. It's a reflex from the investigators, because until now, we aimed that the minimum calcium level, reach the minimum calcium level, when the patient has no clinical symptoms. Therefore, we never ever try to elevate the calcium level upper the norm, upper the minimum. here the target range was 7.8, and therefore including me, until I see the data and the calcium was in the normal range, I didn't uptrate. From now, when I saw that the urinary calcium level is going up, we're going down and not going up from the treatment, I can elevate the uptitrate the AZP3601. It's a very important difference, because in this phase 3 trial, first cohort, we had not enough data about the available data about the urinary calcium. Therefore, we didn't uptitrate the patients in the to see back the proper mode, because in that time we didn't know that. I think from now it would be preferable if the aim would be the range middle part. If it's less than the middle of the targeted range, then we can uptitrate.
That's helpful. And when you discuss, wanting to achieve normal bone turnover in patients, what would that look like in terms of the biomarkers? We saw the data, what turned out, but in an ideal situation, what do we want to see in those markers that's evidencing, a normal homeostasis there?
The main problem in chronic hypopara that the patient has a frozen bone, too low both of the biomarkers. And here it's went up after 14 days, and it's remained in the normal range. Of course, we don't know that what happened after a longer period of time, because we have just 84 days data, but until in this period of time, it was in the normal range and not elevated up. Do you remember that the CTX, which is a main question, it's a bone resorption marker, is didn't going up. It's went in the normal, middle normal range and remained there.
Ritu again, and just a quick follow-up to that. Is there anything better than the CTX and those biomarkers to, I guess, assess or quantify bone and brittleness of the bone, imaging or otherwise?
Not so short period of time. In so short period of time, the repeated measurement is 2 biochemical measures, the only available measurement type. Period of time, the DEXA measurement could be helpful, and there are other available techniques, but CT, some special CT, and so on, if it will be a question in the phase 3 trial. But the bone is a slow moving thing. It's necessary longer time.
We're now going to take questions from the remainder of the audience. The first question is for Professor Takesh. In your mind, how different is the profile of AZP3601 versus other PTH treatments in development?
My personal experience and not is not based on the literature data, just my personal experience, that the AZP3601 was faster. The treatment changed from the calcium active vitamin D treatment to the investigational product treatment faster than other products. And the patient always speaking about this kind of brain fog. This is the first one that the patient can feel. And here it's the quality of life, this kind of quality of life is improved and really fast. I can say some literature data, but I think that the first part of this phase 2 trial is not enough to discuss the literature.
Thank you. The next question is also for Professor Takash. Based on your experience as an investigator in this open label study, have you seen noticeable improvements in patients regarding symptoms, quality of life, et cetera?
It's almost the same answer. I always measure the drug effectivity in chronic hypopara trials, but the patient asked on the last visit that how can I achieve this kind of treatment? And here I can say frankly that all of the patient asked me that, okay, it's ended, that what will happen next? And I said that it's a phase 2 trial. You have to wait for years for that drug, but the needs for this new kind of treatment in chronic hypopara, as you can see and feel from the patient opinion, it's extremely huge.
Thank you. The next question is for Dr. Sumare. Will the company plan to study the long-term effects of AZP3601 on bone health? What measurements will you consider?
Yes, so absolutely, we will, and for two reasons. First of all, one reason is there'll be an expectation from health authorities and also I think from physicians that we follow the impact of treatment over the long term on bone health. Really important for us and important for any drug that's being developed to treat these patients. I think the other reason is because we believe it's an important differentiator for the drug. So it, in some ways, it's additionally important for us to follow it because we think that over the long term, the pharmacology of the drug and all of the facts I explained about the receptor and the effect on bone versus in the kidney will actually be beneficial for patients, not just for the kidney, but also for resumption of normal bone turnover. So we will be doing that. As Professor Takash said, there's a number of modalities which you can use when you've got the opportunity to follow patients for much longer. And so we would certainly do DEXA scanning to assess bone density, bone mass, bone quality. We may also include high-resolution peripheral quantitative CT, which is quite a specialized technique, not available at every center, but could be done in a sub-study, in a subgroup of the sites that participate in the study. But we're very focused on this because we think it's an important differentiator for the drug, as well as important, obviously, for the patients.
Thank you. This next question is for Deb. As a representative of the hypopara patient community, and considering the data just presented by Professor Takash, what is the most important thing AZP3601 may bring to patients?
Oh, there's not one thing. There's basically three things. Number one, it's going to return our urine calcium back to normal, which would be absolutely amazing. Number two, our bodies would start acting normal and actually producing bone turnover. And the fact that it's well maintained or well tolerated, I think that's great. Yeah, Dr. Takash, did you ever hear anything about, or did anyone say anything about your brain? Did the brain fog, did it help any of your patients, or is it still too early?
The brain fog,
Yeah.
after weeks. It's
Okay.
very fast.
Yes, that's the other exciting area.
The problem is that after this kind of treatment, it's come back.
Yeah.
It's when the patient went back to the active vitamin D and calcium, the problem is occurring again.
Yeah.
Thank you for that. The last two questions are both for Professor Takash. If the data you've presented were confirmed in a larger and longer clinical trial, what's the proportion of patients in your clinic that you would consider eligible for treatment with AZP3601?
I'm lucky from this respect because in Hungary, the chronic hypoparathyroid patients treatment is centralized. Therefore, we have lots of patients. And the patients, if we have not a clinical trial, then came back again and again, and they are under the control. And my patients always looking for some solution of the disease. Therefore, I think that I cannot say that 100% because it's not exist, but most of the patients would be part of this kind of trial.
Great. And then the last question we have is, do you think this will change the way we think about target ranges for serum calcium? And now that it appears that urinary calcium may be returned to normal?
I absolutely agree. I think it's one of the most important results of this study, that we can put up the target range in the normal range. From now, I think, it's my personal opinion, that the target range in kind of trial where the hypocalciuria is not a real danger, then the target range needs to be the normal range.
Thank you. This now concludes our Q&A session. I'll now turn it back over to Mark for closing remarks.
So I'll stay here because I think the camera's still pointing in this direction. So I think it just remains for me to say thank you to everybody who connected, who listened to the presentations. And of course, a particular thank you to Deb for joining us. Your perspectives were hugely valuable and very much appreciated, and Professor Takac for being an investigator in the study and being willing to share the data with everybody today. Thanks very much.